right away now. You still can't hear. Okay.
I can hear him.
I can hear you, Jeff.
Okay. Testing. 1, 2, 3. Aaron, can you hear that?
Okay.
Okay. Alex, good morning. Can you hear me? Okay. Looks like we're good to go technologically. So why don't we have a lot to get through today. And so why don't we go ahead and get started and call the meeting to order and take roll. Penny?
Dr. McBride?
Here.
Dr. Smith?
Here.
Dr. Hubner?
Here.
Dr. Khan? He may be out of town. He may not be here. Dr. Garza?
Here.
Nina Riaz?
Here.
And Bishop Hankerson?
He was just here and
He was there?
he said he's at his desk waiting to join.
Oh.
Okay, well, we have a quorum.
Okay.
So why don't we go ahead and start? I think that Bishop Hankerson, I know he's at his desk waiting to join. If, I guess when Ray comes back, then we can have him resend the link.
I'm working on that right now.
Okay, thank you. If you could get that to, okay, he says Bishop Hankerson is only on as a guest. Can we ensure that he is elevated to panelist? Or
It looks like he came in as an H.
What's the name?
I don't know what that is.
I think if you scroll down, he's on there.
Okay.
Oh, gotcha, I see it, didn't it?
There he is.
Oh, okay.
Try to unmute him, Scott. There
There you go.
Okay.
Yeah.
Bishop Hankerson? Okay. He says he's on as a guest. Bishop Hankerson, can you hear us? He must be using a different link.
But why
Public link, maybe?
Is it?
But Ray sent him a link, and I'm sure Ray's working on it.
Okay. Bishop Hankerson, can you hear us?
Hello.
Okay. Hey, Bishop Hankerson, good morning.
Hey, I'm sorry.
That's okay. We got you squared away now. Good to see you.
Good to see everybody.
All right, we are going to jump right in. First of all, I'd like to move, I hope everyone has had a chance to review the minutes of the July meeting, and I'd like to move for their approval.
Move. What word am I supposed to say?
You can just second since I moved.
I did.
Okay, second.
I did, we just didn't have Mr. Hankerson.
Oh, I didn't remember.
Yeah.
I think we need a roll call vote to approve the July minutes.
Do we have to do separate for a closed, or are we just doing it all together, the closed plus the open?
There is no closed.
From what we're approving last,
Minutes.
right? If we were approving the minutes, we're approving both of them, correct?
I believe so, yes.
Dr. McBride?
Aye.
Dr. Smith?
Aye.
Dr. Hubner?
Aye.
Dr. Garza?
Yes.
Ms. Riaz?
Aye.
Bishop Hankerson?
Aye.
Okay, it looks like unanimously the July minutes were approved. So we have a couple big things that we need to get through today. The first, I'm pleased to report that we are we the only facility in the country that has done a racial equity study like this? So, we have talked for the last, especially given the circumstances under which this board was reconstituted, there's been a lot of focus on some of the problems and challenges in the facility, but one of the encouraging things over the last year is that Director Anders and his leadership team have been focused on ways that we can not just look at some of the challenges we've had, but look forward and try to be on the cutting edge of some things nationally. And one of them is this racial equity study that we're going to hear more about today. Scott, do you want to frame this at all and then introduce Dr. Taxman?
Yeah, so we have with us today Faye Taxman with George Mason University, Beth Hubner, our own advisory board member with University of Missouri St. Louis, and Carrie Pettis Davis, formerly with Washington University. Both Faye and Carrie also are from St. Louis, and so Carrie now is with Florida State University and Justice Systems Partners, and they are funded through the MacArthur Foundation to provide a racial equity study, and we have a team now here locally also that will be interviewing residents and staff through focus groups to learn ways that we can improve racial equity within the jail to benefit not only us, but to provide a model for the rest of the country. So we're really excited about that. It will lead to undoubtedly reduction in our population and reduction of recidivism, and also some excellent training for our staff, which will be helpful moving forward. So I want to introduce to you Faye Taxman.
Good morning, everyone. It's a pleasure to be with you. It was a pleasure actually 2 days ago to be at the jail and working with the awesome team that Scott put forth. So I'm Faye Taxman. I'm a health services criminologist. I'm at George Mason University. And as Scott indicated, I have my roots in growing up in St. Louis, Missouri. So my colleague, Carrie Pettis, who is from Florida State / Justice System Partnerships, Beth Hubner, who you all know very well, and myself, put together a grant proposal to work with the St. Louis County Jail that was funded by the MacArthur Safety and Justice Challenge. This is an 18-month project that basically helps develop local solutions for equity-related issues. And what that means is that we're not looking at, what could happen nationally. We're really just looking at the question about within the jail in St. Louis County, what are some of the racial equity issues that exist? What are some of the solutions that can be put forth? And let's start putting forth these solutions. So we're using an evidence-based organizational change process that deals with cultural issues, which we know are the stickiest issues in most organizations. And this organizational process is called Plan, Do, Study, Act, PDSA. It's a quality improvement process that basically has shown to be able to address some of those sticky issues within organizations. We were really pleased that Director Andrews was willing to work with us on this project. This is the first jail, as far as I know, and Beth, you may know more, that is really going to look at racial equity issues, both not only in terms of the residents of the jail, but also in terms of staff issues. And so the process that we're using, the Plan, Do, Study, Act process, involves setting up work teams. So we're going to have 2 work teams of staff and 1 work team of residents. And they are going to be going through a very structured, intense discussions about what are some of the cultural issues, some of the processes within the jail that may impact racial equity issues. And then after identifying these issues, they're going to go through a process by which they brainstorm feasible solutions that can be implemented now. And then, the groups will begin the process of implementing them over this 18-month period of time. The research part that Beth, myself, and Carrie will be involved in, besides supporting the work groups, will be actually to monitor and learn from these work groups about what is racial equity within jail settings. And this is, what we hope to take back in terms of nationally helping to inform the dialogue about improving racial justice issues within the criminal legal system. Another big part of this study is we're going to produce manuals and guide. We're going to work with your team in the jail to really improve their facilitation skills so that they can actually replicate the Plan, Do, Study Act after this 18-month period of time or whatever period of time we end up working. So we're really excited about this process. I learned a ton 2 days ago, so I really appreciate the work group that Director Andrews put together. And we're going to be looking forward to really digging in on this particular project. So I'm open. I don't know, Beth, you want to add anything to it from
No, I think we're just really excited and we're thankful again for the continued support from the MacArthur Foundation, who has been really helpful over the last 7 years. And I just wanted to second Faye's statement that I don't think that this project sort of work has been done in jails. It's been done in prisons, but I think that this is just a great place to start in terms of this sort of research. And we're just so thankful for Director Andrews for letting us in the jail. This is really uncommon. To allow researchers, the media, everyone such open access to the jail. And I think we'll just see a lot of great outcomes because of this. And I think it will help support some of the findings that were presented in the report that we'll be discussing today as well. So I'm excited. So thank you again.
Any questions from the board or anything?
If I could just make a comment, congratulations, Beth, and on doing this, and Scott. All those comments are great, and it is really exciting. And Carrie Pettis Davis was one of my former colleagues, and I still miss her to this day. She's fabulous. You couldn't pick 3 or more better researchers to do this work. So I think it is pretty exciting, and as Beth just mentioned, it sort of aligns pretty closely with the report we're going to be discussing. So it's putting some of this into action, so I got to give you a lot of credit.
Thank you, Faye. Appreciate that.
Thank you. Have a great day, everyone. Take care. Bye.
Thank you, Faye. And thank you, Beth. And yeah, just to add one quick thing. Correctional facilities, as I learned, especially when I was working on my book, are one of the most opaque institutions in American society. So to see your openness and your leadership team's openness to having, everything from CGL to this project to the media to council members, just inviting people in, I think is a really positive step. What people find might sometimes distress them, but sunlight is, I think, always the best thing. And so the more eyes on, things going on, I generally think that's going to benefit the facility. So we appreciate that openness. Thank you again, Faye and Beth, and give Carrie my best.
Okay, will do. Bye, everyone.
All right. Why don't we move on to our next big agenda item, which is a discussion of the CGL report. We've all had the last few weeks to kind of absorb some of the findings, and I wanted to take some time to maybe hear a little bit more from Carl, if you have some opening thoughts, and then give every member of the board an opportunity to ask whatever questions we like. I definitely have some questions. I'm going to give everyone else a chance first, and then if no one asks the things that I have laid out, then I will weigh in. So I have explained, I think, to board members the process that I think will work best, to go around the table and kind of give each board member a chance to ask questions on particular issues. if other board members have follow-ups on those issues that are being asked about, then they should jump in. Otherwise, wait and I'll kind of go around to each board member. Assuming that works, I hadn't heard any objections to that yet. Carl, do you want to just say a few words to kind of frame today's conversation?
Just a couple of observations. One, we were really, really pleased with the degree of openness and cooperation we received from Director Anders and all his staff, from the executive staff down to the officers. We were almost, frankly, taken aback by how frank and open staff were in discussing what they saw as issues with the facility, what they liked about the facility, what they didn't like, the past history. Very, very open, very good discussions with people, not defensive, which is unusual in our experience. As the previous speaker just mentioned, or as you just mentioned, jails can be very opaque institutions, and it's hard in many cases to get a good read on the culture, the operations, what's going on, because they are kind of closed cultures, closed societies. But we found really open communication with the staff at your facility, and that really facilitated our work. The other comment I'd make is that as you look at your operations, your facility, you're looking at it in terms of your own expectations and your understanding of what's happened there over the past few years. We look at it with a slightly different lens. We're comparing you to what we see around the country with issues we see in similar sized jails, other jurisdictions, similar jurisdictions, and we look at your operations in the context of how you compare with those other facilities. So not to say you hold yourself to a higher standard, but we're looking at you in more of a national context. So things that you may deem unusual or you're troubled by, we see these in a number of different facilities across the country, so they may not be surprising to us. So we look at these issues a little bit differently than you perhaps do. But again, it's a different context. So I just keep that in mind as you look at, or you try as you process our findings. But I'm happy to answer any questions you might have.
Yeah, I definitely appreciate that context, Carl. Although, we don't want to be graded on a curve. We don't want to be graded relative to other places that have also had serious challenges, because I think the board as a whole feels that just nationally things that we've seen in correctional facilities are generally pretty unacceptable. And so, we want to be the best we can be and the best, that there is. And so we, although we do appreciate the context, we have high aspirations. So thank you for that lead in. Tim's next to me, so why don't we start with Tim? Or actually, you know what, if you don't mind, I know, Bishop Hankerson, I know you are going to be driving, you're switching to the car in like 30 minutes. And so why don't we, do you mind? Oh, so why don't we start with you, Bishop Hankerson, so that you can be more focused during your opportunity to ask any questions.
Yeah, thank you, Jeff. I appreciate that. And if this question is not appropriate for this time, you can let me know, because as you stated, we're yet absorbing the information. But I was looking at the report where it recommends, this is on page 8, and the next to the last sentence there, require on-site psychiatric service at regular intervals in addition to current telepsychiatry services. What authority would we have as a board to enforce that? Because I noticed it was talking about a lot of the psychiatric evaluations are done by video. And of course, we know mental health is a very important subject matter. So is that an appropriate question for now? Is that more just for the board? Because that's something that I would like to see enforced.
Yeah, I mean, I think that's definitely a question for both Scott and Liz. If you want to address that, I mean, I know from personal experience with family how difficult it is to get psychiatrists in to see people even, outside of correctional facilities.
Okay, so Valerie, would you mind sharing our corrections medicine plan for addressing mental health issues.
Good morning, everyone. The mental health services across DPH and specifically within the within our corrections medicine practice has absolutely, been a priority and continues to be a priority of increasing services, both while folks are incarcerated as well as when they are leaving and trying to support that continuity of care. Historically, the health department has delivered psychiatric care specifically, in addition to the LCSWs and psychologists and so forth, but that psychiatrist license, we have historically incorporated into our practice through a contracted partnership. And those colleagues did come on site. We had varying success with specific colleagues and treatment plans and so forth. And about a year and a half ago, DPH had the opportunity, honestly, for the first time in our history, to bring psychiatrists on board into the health department as county employees. And that was then the strategy that we took in the corrections practice as well as the health center practice. The particular psychiatrist that has been employed with the corrections practice is the one that that does serve as telehealth, and again, challenges and benefits of that from both perspectives. I can say that our strategy within the 2023 calendar year is to try to locate on site contracted psychiatrist services again, but that there's a roadmap to be able to do that and find the colleagues. So we understand that, again, benefits and challenges to that telehealth approach. It's an industry standard in many ways. It's also, any kind of telehealth is challenging within a correctional facility. So that is our intention for that next step in the strategy of service delivery.
Bishop Hankerson, do you want to follow up on that?
I guess that answers so basically, when would you look to have someone on site? And of course, what are the services, you could say, that the psychiatrist offers? Because again, is that dealing with things like depression, dealing with things like abuse that they have experienced in their past? I see that as something so important, because a lot of times that's connected with a person's behavior. So I would just like to know maybe some kind of timeline on when we would see someone on site that could handle those type of issues. And again, Jeff, I don't know whether this is the proper time.
My apologies.
Go ahead.
Thank you. To be clear, we do have on-site mental health services now. We have had historically. That psychiatrist license specifically is what we have deployed as a telehealth model in the last year. But we absolutely do have LCSWs, substance use counselors, et cetera, that are on site in the facility every day, and as well as a nurse practitioner that specializes in psychiatry. And so many of the patient's needs on a regular basis are identified, and we're connecting with those patients live in person in the facility. The patients who need specialized mental health services that can only be conducted through a psychiatrist license are then connected directly to that practitioner. But just to be clear, we do have and have historically on-site mental health care. The on-site psychiatrist approach, that strategy, we intend to have in place at the end of this year, and due to staffing changes within our employee.
Okay, thank you. Yeah, that answers the question, by the end of the year. Thank you.
You're welcome.
It's also probably good to point out that there is a mental health court, and we've established a committee now to look at people with serious mental health issues that are pending their evaluation with the state, and the state has agreed to provide a mobile unit where they're bringing it here to help provide services, and including injectable medication. So there's been a lot of progress in focusing on areas of mental health, and you'll see some recommendations that are listed here in terms of people with mental health issues that may not be able to be in the public housing units, and what can be done to help them and facilitate their process through the courts. So it's a big priority for all of us.
Scott, you referenced the injectable medication. Is that like for people that are receiving like medication-assisted treatment for substance use disorder, or
no?
It's for chronic mental illness.
Chronic mental illness. Okay.
We have found they're not, to help with compliance and taking medication.
Sure.
A shot once a month is better than daily.
Oh yeah.
So if we're able to have them agree to the shot, their mental health is withstanding much better.
Sure. Don't.
So that's the compliance issue.
Yeah, that makes sense. What are we doing? You know, what's the role of the psychiatrist? You talked about specialty, Valerie. You talked about kind of like specialty situations. What are we doing? I know we have like a withdrawal protocol when people come in and they're, you know, actively using and have like opiates in their system. Can you explain the process and the contracted psychiatrist interaction in those situations, and how we get someone towards like medication-assisted treatment, or how we hope to do that?
Sure. Every patient who enters the facility undergoes a standard assessment that includes medical and mental health criteria and characteristics and needs. And there is a clinical protocol that is used at that time of intake to identify patients who may benefit from MAT, from the medication-assisted treatment. Those patients are then reviewed by our medical providers. Actually, that's not a psychiatrist treatment plan. That's our medical treatment plan. And then there's a secondary evaluation that occurs with our medical providers for those patients, and that's where the doctor is determining the appropriate dosage and regimen and so forth. So the patients that are identified, again, through that intake process, or at any time during their incarceration, as identified by our security partners or the healthcare partners as they interact with the patients, those patients that are identified as at risk for a serious mental health need or more individualized, specialized treatment that our lower skilled mental health colleagues are not licensed to provide. Those are the patients that then are connected to our psychiatrist specifically. And of course, during that medical treatment for MAT, if any patient is identified as benefiting from connection with that psychiatrist, then there's that continuity of care as well. Of course, I just want to be clear that the MAT program is a clinical medical program.
Okay, and so just so I'm clear on understanding this, and then does that individual, when they leave here, what is the process? I'm just, it's just you read so much, and I've known several people, who have left correctional facilities and were getting, appropriate, treatment while they were there, and then after leaving had a relapse, within the first few weeks. And I'm wondering if you can tell me more about the continuity of care upon release and what we do, you know, like who the handoff is to, if there is a handoff. And can you tell me more about that, Valerie or Liz?
Let me add.
Okay.
So we have two other organizations that help us also, and Places for People have staff in the jail that are identifying people with mental health needs and connecting them with resources also when they're released. And there's a group called Relink, which is related with the Integrated Health Network, that's also working to identify release resources. And we also have our pretrial staff that are involved in release planning and making sure that's being done. And in October, we plan to do a mass registration for Medicaid that will help assist with their access to medication and medical services upon release.
Okay.
Because now Missouri is no longer one of 13 states that doesn't have expanded Medicaid. So those are some things that are going to really help us moving forward.
Okay. Thank you.
And if they're in the MAP program, they are discharged with medications.
Okay.
They are also connected with the county clinics or a choice that they have, a treatment facility they've chosen to work with, so that there is a continuity of care within the MAP program, along with psychiatric care. As far as with Places for People, we do work on discharge planning, you would call it, but sometimes there's surprises that they get discharged before.
Right.
But
and those two are sent to our choices program. They have follow-up care too. That those people are sometimes in the MAC program as well. So there's a contingency within that program to follow up throughout their treatment with H Street.
Okay. Okay. Thank you all. That's very helpful. Back to you, Bishop Hankerson.
Well, that was it, Jeff. Thank you so much.
You're welcome. You're welcome. Thank you. All right, Tim, you're next up.
Okay, so I appreciate the process, and I got several questions about
sure you
this.
do.
One for now, and I think I'm going to start by sort of doing it in order of the report. And first of all, I just want to say out loud that I think the report is really useful and really well done and very well detailed, and there's a lot of depth to it. And, one of the places I want to start is it's cited in the executive summary, and it talks about, that the leadership challenges, constant turnover in leadership, and then the media perception of the facility is different than what they saw in person. And I actually kind of talked with some colleagues who read the report, read the press reports about it, and they said, well, that doesn't seem right. And I said, I think it is right. And they pushed back on me. So, and as you know, I've constantly pushed back on the fact that the way the media portrays this jail is very different than I think in reality. So I just want to say that out loud for anybody who's listening, because I think that's important, and I stand by what they say in the report on that part of it. I got other questions, but my question on leadership is a lot of that is due to, as we know, to the constant turnover in the executive leadership, as they talked about. And my question is, does the CGI feel that that's sort of been moving in the right direction, or is it resolved, or some of the challenges they found, do they feel like we're moving in the right direction on that?
Well, I think you're definitely moving in the right direction. I think Scott's done a remarkable job stepping into a very difficult situation. His predecessor, Mr. Burris, I think made some very notable positive changes as well. So I think the ship has been heading in the right direction, and just the stability with having a leader in place now for nearly a year now. I believe Scott was named in October last year as director. I think that's a tremendously positive and stabilizing factor.
You could go to others if you want.
I think it'll be good to stick with one person.
Oh, okay. So
and then others can jump in.
Yeah, feel free to jump in if you want. My second question then probably goes to the culture, because that was a big section of the report. And in my service in the board, I keep hearing about concerns about the culture of the jail, and I think that I want to call that out as important. That I think that that's an important issue, and there are numerous reports of cultural problems, but I didn't feel like the report gave me as much detail about that as I really wanted to hear. And exactly what the source of that was, what they found, and how to fix it. Now, this grant may help to fix it in some part, but could you elaborate a little bit more on what you found around the culture, organizational?
Sure. And again, the process was fairly detailed. There's a standard organizational cultural assessment process that was published by National Institute of Corrections some years ago, which we used for this. And essentially, we did focus groups with members of staff from all different shifts, all different parts of the facilities, supplemented that with individual interviews and just walking around talking to staff. And again, our typical experience is that particularly in focus groups, it's hard to get, people can be reticent to share their opinions, and that wasn't certainly not the case here. We found a lot of good discussion in these focus groups. I think, and as you see, the most significant issue that we found that came up from the staff was an issue of communication and having clear direction from their supervisors, finding out what was going on from other staff as opposed from their superiors, not understanding the reason why specific decisions were being made. I think communication kind of underlies a lot of the organizational culture issues that we found. People have perceptions about the promotion process, about how policies get developed, and a lot of this goes to just a lack of effective communication strategy and policy and getting staff involved with understanding why decisions are made and how they're made. That underlies a lot of the culture issues. And I think what we found here, what we see in a lot of institutions, is if you can take care of the communication issue, that ripples through many other specific cultural issues you have in a facility. Communication, just a foundational bedrock issue that has to be addressed to allow you to make progress on all the other cultural issues.
So, hey, I'm just going to jump in here and just kind of drill down a little bit. Yeah, piggyback on what you asked, Tim. One of the things that has bubbled up over the last few years to us as a board and to various people in the community is, and you kind of obliquely touched on this, Carl, but perception of inequities in the discipline process, like internal, investigations, and that sometimes, people in leadership positions look the other way on certain, if certain people committed offenses or were found to have done inappropriate things. I want to ask you what you found, if you heard about things like that, and if people who had experienced that or commented on that found a positive or a negative trend now.
We did hear of instances like that where certain staff who possibly could have been subject to discipline for not calling in or not showing up for work or leaving without permission would go to a certain superior and would get dispensation or some exemption from the normal discipline process. And there was a perception vocalized among several staff that discipline wasn't meted out fairly in that respect. Some staff knew how to get to certain supervisors and get their situations taken care of. That was described as having gone on for some time in the past. Most of the impression we got is that was being addressed, that was not as much of an issue now. There were still concerns about it, but for the most part, the comments we had is that this situation is getting better, and it's not as prevalent as it once was. There were still concerns about, we heard more complaints about the promotion process than anything else, as opposed to disparate discipline. And there were probably more concerns about that as opposed to discipline. We did hear incidences of favoritism in terms of people knowing how to get around the discipline system.
Okay, thank you. Other questions on that topic before we go back to Tim? I didn't mean to like hijack your thing.
You're in charge, and it's a good process, so.
Okay.
You know I'm not gonna get hurt.
Okay, back to Tim.
Okay, so that's helpful. Now I'm gonna move to health. And I thought the report was really strong about going through all the staffing levels and pointing out some of the concerns about lack of staff and you know, I just suggest that people read all that because it gets to the cultural issue in part, I think. That's part of the story. And we know that there's been resources put by the council in correctional staff and that's helped improve things a lot. Now, on the health side, I have to say, and maybe that's just my bias because I know more about health, I think, but I found the report not quite as helpful to me, I'll just say, and not as detailed as the part about the correctional staff. And I think it didn't pull out some of the concerns that I have as much as I would like to have it. And so I just want to say that out loud. It almost might be useful to have a more in-depth look at the health side of the shop, I think, because I don't feel like it was completely resolved. And there, I think the thing I want to point out and have a comment on is staff shortages. It was cited, I think, in the 30% range. And it gets back to Bishop Hendrickson's comment earlier, is with that much staff shortage, it seems to be at the core of a lot of the problem with the health piece. And it's, you know, and it's a systematic problem. We have a hard time finding nurses. We have a hard time finding mental health workers. So I want to hear, you know, CGL comment on that, and others want to comment on it. But that's my concern, is we still haven't resolved the staffing issues in the jail. Is that right?
Yeah, I mean, the staffing issues on the healthcare side are profound.
On the healthcare side, yeah.
Are definitely profound. And again, this is a pattern we see everywhere. The strategy you employ here with employing a lot of temp service nurses is the common go-to strategy, and that creates a number of issues that are described in the report. It's certainly not ideal. When we were midway through this, the county had issued an RFP, was in the process of issuing an RFP for a contractor to come and specifically address staffing issues. And again, this was an initiative that was started when we were almost done with our report. So I'm not sure where that initiative is or what was the result of that RFP. But I mean, that was an example of the county trying to get ahead of staffing issues, at least in some regards, and hopefully they're having some success with that. I'm frankly not aware of what the outcome of that process was. In terms of the depth of analysis on the healthcare side, one of the issues we ran into, and we had a very qualified correctional nurse spend 2 or 3 days at the facility trying to get information. We were not allowed to have access to inmate healthcare records. So it was impossible for us to really get into the qualitative issues in terms of how often they're seen, what are the outcomes of care, that type of thing. That was fairly unusual. We typically, when we do a healthcare evaluation, that type of information is readily available. For, I suppose, HIPAA reasons, the county or the health department opted to not make that information available to us. So we were somewhat limited in terms of how much depth we could go into in assessing quality of healthcare at the facility.
Thank you for saying that out loud. Do you want to see if others have comments?
Yeah, particularly Alex?
Yeah, thanks, Jeff. I think Tim's laid out a couple of the important issues. I guess a couple of things. And I'm going to keep my comments to the healthcare services. So it seemed like there was a lot of, if I can bucket them, a lot of structural issues as far as healthcare personnel. So the lack of healthcare personnel, which I think you rightly point out is not unique to the jail. every healthcare system that I know of in St. Louis and in most of the country is struggling to staff right now, especially nurses. And the wages are very competitive. There's just not enough healthcare workers out there right now to fill the void. So you're going to be challenged with that. I think that then relates to the RFP process, and I think that's a valid issue that we should explore a little bit more, maybe not today, but on how we go about approaching to fill that need. CGL had mentioned in the report the sort of the uniqueness of this RFP in not having the management piece incorporated with the employment piece, and so that may be worth going back and taking another look at. The other piece, though, so that's sort of the structural piece, and then it seemed like there was a lot of process that needed to be better developed. So simple things like, you know, how do you properly dispose of a narcotic and stuff like that. So there's a number of things that seemed like they needed some attention. So, but I think rather than go through these like one by one, I'm wondering if there would be an ability that we could take, you know, that section, not just that section, but any of the sections, and then work through, hey, these were the findings, now what is the response? And I think you're probably working on that right now. And then have some way of I mean, typically people would respond to a report and say, yes, we agree with this, or no, we don't, and then set up, you know, an action plan to say, this is how we're going to take care of all of these issues. So to me, I think it would be more valuable to have that sort of process set up to say, these are the, you know, the 1 through 10 issues, this is how we're tracking them, and this is how we're going to address all those issues. So as Tim probably knows, and other people, you know, when Joint Commission comes through and they give you your list of these are the things you need to improve on, you have to have an action plan on how am I going to fix all these things that they found. So to me, that's a more valuable use of time than really going through these sort of piecemeal, because I think it misses the broader point of this is a very broad report, and we should have an action plan on how all of these are going to be addressed. Does that make sense, Jeff?
It absolutely makes sense. What do you think the best kind of sequencing of steps towards that process would be? Do you think, like, I mean, the one way that I could envision it would be for like each board member to take an area of focus that is aligned with their professional expertise, and lay out the sort of 1 or 2 big, you know, takeaways from that section, and then I can compile that, add kind of my own thoughts, and then submit that to Scott for his kind of, you know, what do you think? Do you agree that these are an appropriate roadmap? And then he can come back to us so then at the next meeting we could formally kind of like approve this is a roadmap that we want to pursue coming out of this report.
Yeah, I think that's a reasonable approach. So if you take just those big sections, you know, from the structure, policy and operations, medical, I'm sure you, well, I would suspect that you could put somebody in a position to say, this is your section to address, right? And come up with an action plan on how we collectively are going to work on the issues that were identified. And then come back with an action plan that says, hey, we saw all of these deficiencies. I mean, even in healthcare, sometimes we disagree with them, and there's a little bit of push back and forth. And so I'm assuming that probably happened with this report as well. But hey, this is the identified issues. This is our action plan to address these issues. You can establish timelines, all of those other things. Bring those back to the board. I don't know if you want to set up subcommittees for each of those different sections, that might be a good way as well to work on that, on those chapters. And then, you know, you had set a timeline for, we expect to have all these issues addressed or eliminated. You know, I'm just making this up, so don't take this as verbatim, like 6 months. By the time we'll
30
get this all
days,
done.
30
Yeah,
days.
exactly. Next week, right? Yeah. So, but I think that that keeps us accountable too. That we recognize these are the issues, and we're taking these very definitive steps to address them.
I like that approach. So, if you, Alex, would you be comfortable, and would other board members be comfortable if I kind of gave assignments based on what I know of your professional expertise to do those top line kind of takeaways, and then I'll kind of ask you, I'll create subcommittees of 2 or 3 board members for each big bucket, and then ask you guys if you guys are okay, and gals, sorry, if you're okay with those, if you know, with that structure, and then we can formalize it at the next board meeting.
I'm comfortable with that if everybody else is.
That sounds
okay.
good to me.
Okay, I don't want to cut this short though, because we have some other people I want. So I think that's super helpful, Alex, in providing overarching structure to how we're going to try to, you know, provide advice and guidance in the execution of this. And Scott's nodding, so I think, you know, that's good. Can I go on to Beth?
Well, I have a question. I mean, I think this is a good idea. This is how I've always done a review like this, but I'm happy to look at a section and take responsibility for that, and work with the team. I don't know all what's been changed since the report. So that was my question, like some of the staffing, you know, has that been improved? So like some of these data I don't have access to, so that like we can't respond to a lot of these things because we don't have all of the information, correct?
I can give you an update.
A lot of this has to be done by the jail team.
Yeah.
How about when we finish giving our feedback today, Scott give us kind of a, here's the things that I've done, because I mean, you got some preliminary findings from Carl 3 months ago, and you've already been, you know, that's about right, isn't it? So there's already a bunch of stuff you've been doing. So when we finish this little round of feedback, then you can do that, which will help us formulate our top line. Because some things that we might want to do, that we might want to push you on, you might have already done.
Yeah, that's kind of what my question was. You know, there was a lot of discussion of incarcerated people being in the cells a lot. So I just wondered, you know, has some of that changed in terms of, since you have hired so much staffing in the last couple months? So I'll just tell you my 3 questions. I was also just wondering about, you know, the use of force reviews and the death reviews, what role the board would have into that, if any. You know, and I guess I think it would just be helpful to continue to refine and detail the role of the board now that it is more established over the last couple of years. And then the final thing is just like, how will this report be communicated to the county executive? And, you know, is there funding to address some of these things? I was just wondering how that would, what the next step with the county executive would be.
So I apologize if I was remiss in my role here by not letting you guys know this, but I have discussed the findings of the report with the county executive. If, you know, in an informal way, you know, just talking through all of it, so he has been briefed on it. I think that he has placed a lot of trust in our advice and our kind of backgrounds in this. And really, his response to it was, I trust the board, and I want you guys to, and I trust the leadership team at the facility to, to run with this and to make the changes that are suggested. There was, at no time has he said over the course of this process since the day that he, after we all resolved at a board meeting to push for this review, he never said, don't do that, or wait to do that till after November, or anything like that. Everything he said was always, let's go ahead and do that, and I want to hear what you find, and I want to put resources behind it. So I think the real question where the rubber meets the road is going to be for the things in this that are going to cost money, and whether we're going to get support from both the council and the county executive for those things that will, require some hard decisions, at budget time. So I think that's probably another question. If you feel like we should formalize those conversations, I think while I briefed the county executive who specifically, was interested, I think it would be useful for us to potentially do like a formal briefing of the council. So I'm happy to reach out to council leadership and see if they would be amenable to that. Beth?
I think there's just been such a concern about transparency that I think there should be, a formal presentation to him, to the county executive, to the board. And then I always get concerned that some of these will be like unfunded mandates. So, there's a lot of great suggestions in here that will cost money. And so, if we really do want to see clear change in the jail, I guess I just wondered how the county executive is going to put that into his budget plan or the, I guess I just wanted to make sure that there's some support for these, because we see a lot of like blue ribbon panels and reviews like this, and then nothing changes if we're here like 5 years from now. So I just want to make sure that there's immediate clear follow-up.
So, and Beth, Carl actually did present to the county executive and his executive team. So I'm working together weekly with the leadership team here on an action plan and briefing the executive staff for the county executive. So we're working closely on all of these things, and we've already implemented 15 of the recommendations. So I look forward to, after the questions today, giving an update on where we're at. And there's a budget request in already in our budget that's been submitted for next year. So I think we'll be able to answer some of those questions a little bit later in the meeting.
Could I jump in, Jeff? Just on these two comments, piggybacking on them, I totally agree with what Alex said about process and Beth and what you just said. I'm kind of a concrete kind of linear person, so what I think, in addition to what Alex suggested as a process, I'm envisioning a spreadsheet of all these 71 recommendations in sections, and I know you sort of have one there. So, but it would be like recommendation, progress to date, timeline, budget needs, something like that. You could have like 4 columns, and then if like I agree with Beth. I mean, I've learned enough in the last 3 years to be able to comment on some of this, but I'm not here every day. I don't know what's happening in terms of operational changes, so I would like to see that. And then if we want to say push harder on that one, or that sounds great, or so that's a recommendation I would make, is a spreadsheet and all these 71 recommendations. We don't agree with this recommendation, whatever you say. Does that make sense?
Yeah, we have a spreadsheet we can share with you. I printed in PDF form today, but we're working through a spreadsheet. It's a shared document. We've made great progress in it. We have all of the components along with who's responsible, target dates, the completion date, and notes along the way. So we'll share that.
That would be really helpful, I think.
He just let us get all lathered up about how we're going to do this, and he's already been doing it. Which is so. Can you? Sorry. Can you share that link with me, and I can share it to the board, and that'll give us, you know, a solid framework for what we're hoping to do, and then we can work with, you know, and potentially, one thing that I would like to do as a board, I have some interactions with other members of your team, and I'm probably here, you know, a little more than most board members, but I would like for more board members to get to know more members of the team. And so I think it could be good if, you know, for the committee member, when we establish these committees, and then those committees of 2 or 3 are working with your reports who are deputized to execute in these different spaces, I think that will deepen the collaboration between the JSAB and the jail. Do you guys agree with that?
Yep. Aye.
Okay.
Did you want to go to Nina? I got one more question after that.
Yeah. Nina.
I have no questions at this time. My esteemed colleagues have addressed all of them.
Okay.
That's great.
Okay, that's good. That's good. Let me go back to Tim. I think Tim has a couple more things.
I got at least one more thing, and it piggybacks a little bit on what Beth said. And, you know, for the general public reading this report, I think the perception of what they expected and what they got is a disconnect. To me, it wasn't that much of a disconnect because I know what we asked for, and I think we largely got it. But in the reading of the press, which is increasingly driving me crazy, and how they perceive what this report was expected from this report, they expected it to be a detailed report on the deaths in the jail. And, you know, especially those 5 in 2019. And they read the piece and they said, well, it didn't give it to us, and therefore we're disappointed. We think this report's not giving us what we want. 2 things about that. One, I think that's a misperception of what the report was supposed to do. But second, I remain sort of frustrated, and it gets to Beth's comment, that I sit here as a board member and I still don't understand all the details of what happened in those deaths. And, you know, and I have gotten reports about these deaths, but they're like whatever, you know, they're heavily redacted with a lot of blacked out stuff. So I don't really understand that. So as a process point, I struggle with my role as a board member in the HIPAA things were brought up earlier that CGL struggled with as well, that, you know, if somebody asks me why those deaths happened, first of all, I can't say what I'm not supposed to say, but also I really don't know. And I'm not sure as a board member what our role is in that process. And I have to say that's one of my biggest struggles that remains as a board member. And, you know, and I just want to state that out loud, and I had the same struggle that CGL did, and I don't know going forward, we have to really clarify our role in how we deal with jail deaths. And I don't think that's resolved because of HIPAA concerns, legal concerns. I don't know what the barrier is, but you know, there is a barrier there, and it's somewhat problematic, I think.
Yeah, so a couple of things about this, because I've come long after that, and we're focusing on the future moving forward.
Yeah.
And there have been a lot of improvements. But, and I think Carl can add to this, but Bureau of Justice Statistics recently reported that on average nationally there are 2 deaths per 1,000 inmates. And if you look at the jail as kind of a community, just like the community.
Exactly.
And there will be deaths, and so there are reviews, and there were police investigations in each of those, and there are ongoing legal matters that all result from those things. And even now getting coroner reports take time because there are so many deaths related to fentanyl. So I think, so you have internal investigations, you have police investigations, you have legal matters that follow, and the focus that we have now and with this review are what can we do to continuously improve the process, which is why, and we're fortunate to have Department of Public Health on site here, where most jails don't have that, and they contract. And and they provide excellent care, and as Dr. Garza pointed out, even in the medical field in the hospitals where they pay substantially more, there's a shortage of medical staff. So we have to be creative and innovative about how we find staff. So we've pulled our way out of being 84 officers short to being less than 30 officers short now, while other correctional facilities are going the opposite direction. So when it comes to this, I think the focus with this report is what I had hoped for and what I expected in terms of what we could do moving forward to make sure that we're improving. And you never want a death, and you always want to make sure that those processes are put in place to conduct a review. And I think while the legal matters are pending, it's you know, we'll have to see how all that comes out. But we do have answers in terms of the criminal investigation. We do have answers in terms of the internal review, and so that's my thought in terms of the board. There may be some things that we can do to improve processes.
Yeah.
That would be what I would see the role of the board.
Yeah, I mean, I think we all felt frustrated around our limited understanding and access to information initially around the 2019 deaths when we came in. I appreciated the transparency around the more recent losses of life, where, we heard within, I think 12 hours, kind of what had happened. Between you and Valerie, I was able to understand, just have a kind of a baseline understanding of time frames, contact with healthcare personnel. Everyone was open about it. We had kind of minute by minute understanding of when someone was seen, who saw them, when they were transported to the hospital, what the, particularly in the one case where the individual was transported to the hospital immediately and then transported back here within 24 hours. It gave us, obviously it was very, a tragic thing happened, but it gave us some level of comfort that people here had made a correct, immediate decision, even when, and maybe a more questionable, I'm obviously not trained to make this comment, but the fact that they were sent back here, by the hospital and then passed almost immediately after would certainly seem to suggest that the healthcare decisions made here were solid. So I would like to use, and I'd be curious, particularly given Alex's, subject matter expertise, how you felt about the most recent incidents and the information flow that the board received.
So I think to your point, Jeff, it certainly has evolved from the time where we were first established as a board, and has become much more, I think, information forward and transparent. So, but getting back to Tim's point, I think what we need is an established policy or process that says this is how a death review is going to be going, and including a legal review for how involved should board members be. So if I remember correctly, and somebody can jump in here, and again, we don't have to solve this today, but I think it's something that we need to put on the list of things we need to figure out. So before there were some legal rationale, stuff like that, but which is fine, but that needs to be clearly spelled out so that everybody knows what their roles, responsibilities, authorities, and accountabilities are. And so I really think that that's what you were asking for, Tim. If I don't want to put words in your mouth, but if we just have a clear process and language supporting that says this is what the process should be like, this is how involved the board should be in these sorts of things, so that everybody just understands this is my role, and then we can move forward.
And Valerie, this is something that you and I have talked about especially a few months ago, kind of talked about notifications and information flow, and you know, you had a document, I believe, that you were working from during that time. Valerie, are you there?
Yes.
Yeah. I believe you were working kind of from a document when we were working through the last death.
Yeah, I'll circulate that to the board after we conclude today. It does from, I think from our official working perspective, it probably remains still in a draft from where I say that, meaning that I don't know that the board had officially approved that that was the decision to go forward, but organically, that's certainly what we've been working along. So I'll circulate that, and it does outline the timeframes and the type of information that would be shared at what point, you know, making the assumptions of what we would know as that time progressed, referencing what Dr. Garza was speaking about. So I think let's dust that off and have new eyes on it and get to a protocol that meets the complexities of what we have to be aware of as the situation and just time progresses, and also provides that level of information so that the board understands, you know, really the action items, right? The lessons learned, and then confirmation that those procedural or communication processes and so forth are actually being implemented. That really was the essence of that framework of communication, was to demonstrate this is what we, first of all, we followed best practices at any kind of inpatient death or in facility patient death, and then demonstrating that we've actually implemented those lessons learned.
I just want to endorse what Alex said as a process. I think that was what, he's always more articulate than I am, but that's exactly what I was looking for, because we don't need to actually do it as the board, and I don't think we're allowed to do it. But I want to be clear that there's a process that we've agreed on and that it's being followed, and that we can make recommendations to the change in the process. Yeah. That's our role as a board, is not to actually do the investigations, although, you know, I'd like to know more, but, you know, I feel it's gotten a lot better since we started, for sure. And we want a timely response, and we want to trust the process.
So Jeff, do we know, and maybe this is a question for Carl, do we know if this is similar to how other jails do investigations? I mean, particularly in the relationship with the board.
They're a little bit unique in that most jails don't have advisory boards like this. So
okay.
Other than, you know, some of the very large metros, LA, New York, those type. And in those instances, yes, this is pretty typical. They want to be involved. They want to have some level of oversight, some level of vision into what's going on in terms of investigation of deaths. So it's a very high profile issue. So this is very consistent with those systems that do in fact have advisory boards.
Would we be able to see examples of how they're involved, though, and to what level they are?
I can do some research on that for you, sure.
Okay, thank you.
Thank you, Carl. Thank you, Alex. So a lot of the questions that I had have been asked, and I know we have other stuff that we want to get through with the dashboards, but one thing that jumped out at me, Carl, was you talked about the staffing pattern being top-heavy, and I think the numbers you suggested in the report that you prescribed was a reduction in majors by like over 50%. And I was wondering if you have a prescription on how to achieve this. Is this, you know, I think, you know, you prescribed it in the short term. So is that, when you prescribe things like this in other cities, has that been achieved through just demotions, or if people are near retirement, you know, attrition, or, you know, some mix thereof? And did you have specific recommendations along those lines?
Most typically, again, we're talking about people who've had in most cases, long careers with the system. They've devoted a lot of years to the facility. So the most typical way to implement something like this is through attrition, allowing people retire at their normal retirement time and then transition to a more lean command structure as those people depart. I think in some of the instances here, some of the major positions were already vacant. I think a couple of the others, the individuals were in ill health and maybe contemplating retirement. So it looked to us like you were going to be able to transition to this leaner management model sooner rather than later, just based on where several of these people were in terms of the arcs of their careers. But no, I think you do this through attrition.
Okay, that makes sense. Thanks. Thanks for that response. All right, so just some action items coming out of this, I think, really constructive conversation. First of all, I'll work on board subcommittees to help guide follow-up implementation of the report recommendations. Scott will send me the link to the shared document that I can disseminate to the board to help guide our participation in that. Valerie will send to the board the document that she used and that the leadership used to guide us through the last death. Is there anything else that I'm missing?
We will, no, I think that's a pretty good summary. We're gonna, once we get that spreadsheet, the 71 recommendations, it would be great if you could set up a process to kind of, maybe not go through all of them in one meeting, but we could, you know, review them and just bless them or comment.
Yeah, and then the only other thing is that I will reach out to council members about the, and just ask if they would be interested in a, you know, because there had been a lot of vehement responses from a couple council members in particular about questioning transparency of the facility. So I think it would certainly behoove us to, and behoove the jail leadership to say, hey, here's what was uncovered, and here are our planned next steps. So I will, Penny, thank you very much for your faithful recording of everything that I just said. You did, right?
I got it all.
Got it all.
Yeah, I thought that was a good suggestion by Beth to bring it back to the board, or and the county executive will be there. So if you or others, we can all sit there and cheer you on, and you know, just sort of say, we got this. Here's our response. I think that would be a good way to close the loop.
Definitely. Thank you, Beth, for that suggestion. Okay. Is there anyone else who wants to be heard around the CGL report?
Could I make just one quick comment?
Sure.
You know that I can never shut up. Again, I thought a lot of the report was really good, but just a question for CGL. This is my hobby horse, as you know, I bring it up every meeting. I think the health staff has done a remarkable job of dealing with COVID in the jail. And I was a little surprised that it wasn't in the report. And, you know, because I think, you know, we get constant reports about what's going on with COVID, testing, vaccines. And, you know, I think for full transparency, the good, the bad, the ugly, that's one of the good things that should be in the report, I think, is about the COVID response. And I was a little surprised. It was in there?
Yeah, it was in the chapter 7. I remember distinctly seeing it.
Okay, I apologize if I missed it.
Yeah.
Yeah, I mean, it wasn't a huge part of the report, but it
correct.
Maybe that's what I was bothered by.
Yeah, okay, but it was mentioned.
Okay, all right, apologies.
But it should certainly be something that I think we should highlight to the council.
Okay, I'm done.
Okay. All right. Carl, thanks for all your work. And thanks for your accessibility over the last few months as we've work through this and for your agreement to continue looking into a couple things, that we and that Alex asked about in terms of board processes in other cities. So we appreciate your diligence.
Happy to do that, and really enjoyed working with you all. So good luck.
Thank you, Carl.
Okay, Carl.
Hey, Tim,
All
it was page 87 under infectious disease, if you're looking at the report.
Okay. Thank you.
You're welcome.
All right. Why don't we move on to the next agenda item? Aaron, you want to take us through the dashboard?
Sure.
Thank you.
Okay. Yeah, I actually refreshingly don't have a whole lot of concern with much data this month. The daily population I just wanted to go over real quick is, if you look at the overall trend since about, February or so 6 months, we were in the high 800s, and now we've been pretty steadily in the low 800s. We're at 825 as of this morning. Other than this dip that we had in the end of 2021, the overall trend has been really nicely, consistently downward over the past 14, 16 months or so. So that's good. Otherwise, length of stay has been bouncing around the same numbers lately. Our use of force went down in July versus June. Generally been pretty low lately, so that's also good. And I don't think I had, on the supplemental dashboard, I'll just mention that the number of open correctional officer positions for at the beginning of August was pretty similar to the beginning of July, but for what Scott just mentioned, I suspect that's going to go down further in September if we are, did you mention we're under 30 now?
Yes, yeah.
Yeah. So I think that will be down because at the beginning of August it was 39. So this chart here and then the ratio of residents to COs hopefully should continue to both improve next month.
And in accordance with the improvement in those two measures, we should probably see a continued downward trend in overtime hours worked.
Yeah, I would hope so. I mean, if you look at the trend since about what's May, so 15 months ago, it is slightly downward. I mean, it has been dropping, bit by bit. It's been gradual, but hopefully those two things will also improve that metric as well.
Yeah, I have a question on that. I guess I mean, it is notable improvement in the number of corrections officers, but the drop in overtime hours has been pretty gradual. And should we be expecting a little bit faster drop in that, or?
Well, so the challenge is, there are a couple of things happening now. The Civil Service Commission is looking at revising the overtime policy for the county, which would make it consistent with the Fair Labor Standards Act. Right now, if an officer doesn't report for a shift, they'll earn overtime if they work another shift, which doubles our overtime because we're covering the shift that person didn't come to work for plus the additional shift. And so just that policy change will significantly reduce overtime. And then the other challenge, which was noted in the CGL report, is that appropriated staff number. So right now we have an appropriation of just enough to cover shifts. So if they're not reporting to their shift, we're going to be using overtime to cover that shift. So CGL pointed out in that report that if we were to increase staffing levels even slightly, that would save $1.6 million in overtime. So that's the request that we'll be making through the budgetary process soon.
Other questions regarding the dashboard?
Yeah, I think for the DJS dashboards, that's actually it for me. A pretty simple month on data. Oh, just the last thing I wanted to mention.
Aaron?
Yes.
Just real quick. we have, if you know, the ER run trend is positive from a few years ago. I'm just wondering if that 2020 data, was that, if you went back to like 2018, 2019, is it more characteristic, do 2018 and 2019 look more like that first half of 2020? Or do they look
I
more
only
like
have
we
the
are now?
supplemental data going back to the beginning of 2020. So it would be, that would be interesting to see, but I don't know offhand. It does look like it changed right as COVID happened.
Yeah, yeah. Okay, thank you. I apologize for interrupting you.
Well, you also
No problem.
added
The only
24-hour providers.
I'm sorry.
Okay.
I'm sorry.
Yeah. Okay, go ahead, Aaron.
No, the only other thing I was going to mention is that, you know, I've been waiting a long while to switch these dashboards over to Tableau, which is a much superior visualization program. The thing that's been holding it up is that, and this is not a fault of anybody, but it's just a gradual process, that since there are a couple windows that I update on a daily basis, the infrastructure that the county data team is building in order to sort of the equivalent infrastructure, data infrastructure that the county data team is building that will kind of match what we do now for the ArcGIS portal is finally getting to the point where it's ready to ingest daily updates. And so I actually have a meeting with the new county data officer in about 4 weeks. I believe it's the same week as our next board meeting. And so though the dashboards probably will be still in Arc at that point, just because it's only a couple days before our meeting, it's also my hope that they'll finally be able to be transferred over that following month.
Okay.
So that, I think that's it for DJS dashboard. Does anybody else have any questions for me? If not, I can hand it over to Liz.
Thank you. Really, truly, there isn't any outliers as far as our statistical and medical data that we have been reporting. Just have safety concerns continue to be reported, and we always look at the process when those are reported as far as how we can improve our medical care, our daily direct medical care. And so if there's any questions, if you're able to, anybody reviewed and had any particular questions in regards to our statistics that we produce for the month of July, I can answer those questions. But there was nothing as far as outlying changes, demographic stuff.
So I got a question on the substance use disorder graph, the red one on there, if Aaron wants to pull it up big. You know, I agree that most of this looks pretty steady. But I'm just wondering about that peak in May. So it seemed like we had it's a pretty fairly steady, and then it bounced up in May, and now it's going back down. Do you have any thoughts about that seasonal or what?
People going outside again? And
yeah, I just didn't know.
Well, I will want to say that all of our statistical data is based off of cooperation. So upon entering into the facility, if they happen to give a urine sample, then we were able to report particular substances and if there is anybody using. So we'll just say during the month of May, we may have had more cooperation than we did with the month of June and July, because everything we report is based off of the information we get from the patient, and that's their cooperation. I don't know that I will say that the community at large was using far more in May than in June or July.
Yeah, okay, great.
So along those same lines, then, do you know the percentage of people that do cooperate in any given month?
We do have that statistical data. I would have to get that information. But yes, we do, with our electronic health record, we're able to who provided a sample versus how many were actually booked
Mm-hmm.
during that month. So we have so many that were booked, and then how many actually provided us with a sample.
Yeah, that would help guide that discussion.
That's great, thanks.
Any other questions? I will give my monthly statistics on our COVID. We gave 22,603 tests, and we had 552 positive COVID cases within our facility. So once again, we currently are COVID-free, except for maybe a couple of employees that have tested positive. But other than that, we have nobody in our facility that has COVID.
So you have 22,000 tests, 500
And 52 positives, yeah.
52, okay.
552.
500.
Okay, so about 5%-ish.
Yeah.
Which
Those
seems like.
tests are voluntary as well, correct?
Yes.
Yeah.
That is
You
correct.
don't have COVID that you know of.
This is correct as well.
Okay.
So if they choose, they're cooperating more so with that because that cuts down on the time in isolation. So if you don't take the test, then you're in longer than if you do cooperate.
Oh, that's a nice.
So, well, that's medical. That's not.
I know.
That's not me. That's all medical data there. Our recommendation by the CDC.
Okay.
Alex would know better than I am, but these numbers look almost better than the community.
Than the community, yeah.
Yes, they do.
That's great. Yeah, continued praise for your work. Thank you.
I'd like to compliment them too. With people coming in to jails, typically a lot of them have been using drugs or alcohol before their arrival, and we've just had a couple of staff that were recognized for life-saving efforts, and the medical unit responds, administering Narcan, and so those are the things that people don't hear of every day, and I just want to compliment them on how quickly they respond.
Thank you.
Yeah, thank you. And if you could, if there are a couple individuals who Scott referenced, if you could send me like their email address so I could send them a note thanking them on behalf of the board, I would appreciate that.
Okay.
Okay.
Hey, Jeff.
Yes, Aaron?
One other thing, just before we wrap up, I wanted to answer your question. I looked back in my files and I found ER runs data going back to the beginning of 2019. So just one year prior. And it looks like for the 6 or 7 months before January 2020, the per 1,000 residents rate was bouncing between the mid-20s and the low 40s. So I actually think this was an relatively oddly high point. I think it was more in this range, a little higher than it was before, but I don't think it was, I see 2 months over 40, nothing over 50 or 60.
Okay.
Yeah.
Okay, thanks for going back and looking at that, Aaron.
Yeah, I wanted to go look and see if I had it. It turned out I had 1 year of historical files on that.
All right. Are there any other questions about the corrections medicine dashboard? Okay. Thank you, Liz. Is there any new business that people want to raise? Okay. Is there any public comment, Penny?
There were no public comments.
No public comments. Okay. Our next board meeting will be 9 o'clock on September 23rd. We've all got our to-do list, and so we have a lot to do before then, and we have a lot to do more broadly. Thanks to this report. Scott, I know it's a lot to run the day-to-day and manage the day-to-day, and Randy and Darby, I know, and Liz, I know it's a lot to manage everything that you have to do every day, but then also keep in mind these you know, a whole new set of recommendations for what you need to do in the future and manage the big picture stuff along with just all the emergencies, you know, the things that pop up every day. So we appreciate you guys walking and chewing gum at the same time. I know it's not easy to operate on 2 tracks like that. So thanks, and we look forward to drilling down into the recs and putting our subcommittees together. Thank you, board members, for your thoughtful input around the report and in advance for your work over the next, you know, several months in helping make all of this happen. We will see you on September 23rd. There's nothing else. Is there a motion to adjourn?
So moved.
Tim has moved to adjourn. Is there a second?
Second, Garza.
All those in favor say aye. Aye. All those opposed say no. Looks like unanimously we have chosen to adjourn. Everyone have a great weekend. Take care.